Hi everyone, welcome to Care Culture Talks. My name is Eyal Heldenberg. I'm the CEO of No Barrier, an AI medical interpreter for healthcare providers. This podcast is about language accessibility and cultural competency. Happy to have a dear guest in the podcast, Luis Simmons. How are you today?
I'm doing well. Y'all and yourself?
All good, all good. Perfect. So maybe we'll start with just a quick intro. Luis, could you kind of guide us through your journey in healthcare?
Sure. Well, again, thank you so much, y'all, for inviting me to the podcast. I look forward to sharing my experiences as well as this very interesting topic. My journey into healthcare is that I have been a part of the healthcare community for over 15 years. I began as a administrative fellow at Emory Healthcare, and then from there I decided to focus my attention on acute care operations, and so I started in the perioperative and endoscopic space for over 3.5 years for Emory Hospitals in Atlanta, Georgia. From there, I decided to progress in my career and wanted to gain more experience in the physician group practice arena. So for over 10 years, I've been focused on the physician group practice management side of healthcare. And so I also began that journey at Emory Healthcare, specifically Emory School of Medicine, and then had an opportunity to also work on the Emory Healthcare side for a multi-specialty clinic. And then from there, I migrated to work for community health systems, one at Athens Regional, more specifically Athens Regional Health System, as a director of assistant director of practice operations. And then I moved from there to join Morehouse School of Medicine and be a part of their faculty practice plan at Morehouse Healthcare, still doing multi-specialty physician group management, and then had a wonderful opportunity that I couldn't resist to come to where I am today, which is Whiteford Inc. We are a nonprofit based in Atlanta, Georgia, more specifically the Edgewood area. And we are a organization that has been practicing for over 30 plus years. And we've been practicing in a couple of spaces. One space, we have a early learning academy, and then that we have operated for a number of years. And then also we have what's called a federally qualified health center operation, where we have 5 clinical care sites that are deemed federally qualified health centers, or also known as community health centers. And 3 of those are currently within school-based health centers environments. And so we partner with both the Atlanta Public Schools as well as KIPP Metro Atlanta. So for over 15 years, I've had the opportunity to lead in both acute care and physician group settings, as well as been able to manage areas like revenue cycle management, project management, financial analysis, financial budgeting. So my focus has always been operations for each of the entities that I work for. And that is a nutshell for me.
Amazing, amazing, perfect. So maybe we'll hone on this community centers experience. I think
Mhm.
it's called, also the safety nets across America.
Mhm.
There is kind of a known knowledge that these specific segments serve a really diverse patient population. Um, can you guide us through, like, what are the unique challenges?
Yes. So we are a what's called, as I said earlier, community health center. And so we are under the umbrella of the what's called the HRSA 330B program, which funds fairly qualified health centers. And those centers are either what's called lookalikes or, community health centers. And what we do is we actually serve in what's called um, medical underserved areas. So what we do is that we provide services to a community that's deemed a medically underserved community, and that could be based on not having specific providers in their area to enable community members to receive the care that they need when they need it, or also what's called medical services underserved populations. So that you may be in a population where you are considered to be a medical underserved population based on the types of services that are needed or not available. So these community health centers serve as a access point for patients, particularly patients who are what's considered low income, compared to what's called the federal poverty level guidelines every year. So specifically for community health centers, more so what's called federally qualified health centers that we have to provide what's called a sliding fee discount program, which means any person that is 200% or below the federal poverty level, we are required to provide reduced services on
Hmm.
fee for the services that we provide. So for our center, what makes us unique is that we provide medical dental and behavioral services in one location. What also makes us unique too is that we not only accept commercial insurance plans, but we also have this unique sliding fee program, which is specific and required for community health centers. Now, the other piece that is important too to note that you mentioned is that we are a part of the safety net umbrella, and that is true. So we serve collectively federally qualified health centers across the country, which there are thousands of them, over 1,000 of them across this country. I think the last number I remember was over 1,400. And we also provide services in a year to over 30 million Americans. So when you think about it from that perspective, we serve a number of patients a year, and these individuals receive quality care from these community centers. So that's also what makes us unique, is because not only do we provide care to low income individuals, but just like private health institutions, we provide care to all that will come to us. But in particular, we're known to have a sliding fee discount program. And so therefore we are a clinic that can cater to and is really developed to support persons who are 200% or below the federal poverty level. So that's how we are integral into the safety net umbrella, because we provide that access point that a patient may not otherwise have. With that said, we also are what I like to call a connector to specialty services, because as a federally qualified health center, you are required to provide primary care services, and that could be in the form of a internal medicine physician or family medicine physician, pediatrician, or a OBGYN physician. It could also mean it could be provided by what's called a mid-level or associate provider, which is a nurse practitioner or a physician assistant or a certified nurse midwife. So when you think about it from that perspective, it's really creating a primary care pipeline for patients to receive care, and then that primary care unit then links them with specialty care when needed. So yes, we are considered part of the safety net umbrella, and we provide exceptional care, I think, to anyone who needs health care, but also we do it in the privacy and background of their own community. So that's why we also here at our organization refer to this as place-based care. We want our community members who live in the community, and we want them to come and receive care at our health center, so that where they live and play, they can also receive quality health care from qualified healthcare providers and from a very supportive staff.
Yeah, I think I read in LinkedIn that the FQHC got into a very efficient level comparing to other, may I say, private operations.
Yes, I think, we have learned, and historically, I believe community health centers have learned to be efficient, but they've also been, also from a governmental perspective, we are assessed on an annual basis based on specific criteria. That could be what's called universal clinical quality measures that we have, to where, we have to report annually to the federal government, specifically HRSA, which is the Health Resource and Service Administration, through a program called the Uniform Data System Reporting, that
Yeah.
we have to report on over 16 measures now, because it changed. They added 2 more this year, which are related to substance use disorders. But we have to report every year on measures such as diabetes management, hypertension management, cervical cancer screening, HIV screening. Now, this is not different from other measures that we have to report to specific payers, like HEDIS measures, et cetera. But we also have to report from a Federal Tort Claim Act perspective, in order to receive medical malpractice coverage from the federal government, we also have to report on our specific programs, such as our quality assurance program, our risk management program, our claims management program, because they want to make sure that the program is ensuring that they are credentialing and privileging all of their providers and staff as appropriate, that they are enacting and are sustaining a quality and robust clinical risk management program, and also similarly a robust quality assurance and improvement program as well, to ensure that we're providing quality patient care. So because we are required to report those things, it also allows us to ensure that we are evaluating ourselves appropriately, to see if we are providing quality care to our patients. And that's also a way for HRSA to assess and compare and contrast to not only other federally qualified health centers, but also through the nation and comparatively in the nation, if we are providing quality care. The other piece of that is every 3 years, similarly to Joint Commission, which they do it on a multi-year basis. They evaluate hospitals and they also do clinics. For us, we have a similar accreditation process that is every 3 years. As a matter of fact, we are slated to have our own upper side visit, which is what it's called, for our organization in June. And that specific evaluation reviews 19 areas of your entire organization. That's everything from your needs assessment that you're supposed to do every 3 years, and asking the question, do you use that data to inform the services that you provide, to looking at board composition, board authority, and conflict of interest, as well as clinical staffing, et cetera. And that is important because similarly to Joint Commission, they too want to make sure that there is an assessment in place to evaluate each entity to ensure that they are and are being cognizant of the appropriate processes and procedures that they need to have in place in order to continue to provide quality patient care, as well as to create positive patient experiences, and also thirdly to have a assessment to provide information to the health center on ways to improve. So I think because of all those things, I think it has been assessed, as you said, in studies that federally qualified health centers or community health centers or even the lookalikes, that we're able to provide and sustain providing quality patient care, and to be very efficient because we've had to for various reasons. In a lot of organizations, we are not resource rich, but
Right.
we've learned various ways on to how to be efficient and lean. Even this organization that I'm a part of, we are lean, and that's not uncommon in a number of community health centers. And also too, because because I believe that as a part of being a member of the community of our FQHCs, we are highly, connected to our communities. So I think that's the other benefit too, from a perspective of our engagement and our intention. Because we are so focused on ensuring that our community has the services it needs when it needs it. That helps us to be more engaged, as well as it helps our performance. And so that's why I also think that you have an opportunity to receive quality care, because we try to be very connected. And so to have the ability to have all your services in one location, like oral health care, in our example, we have medical, dental, and behavioral services. So we were able to provide that one patient all those services in one location.
Yeah.
In comparison, they would have to go to multiple locations from a private care perspective. They'd have to go to another area for dental care. They'd have to go to another area for primary care. They'd have to go to another area for mental health services. So to be able to do that in one location, as well as to do it in real time, because that's what we sometimes have to do, and we call those warm handoffs to other services. That is one of the hallmarks, I think, of a federally qualified health center. That happens, and that does not happen in a vacuum. That really happens in a coordinated fashion. And so, from that perspective, that's already providing a model that's different when you compare it to being an academic medical center or a private environment most of the time. So I think that's the other, advantage of being a part of an FQHC.
Perfect. So I think let's go over language barriers.
I think they can definitely be impacted by the level and types of care that a person receives. From a federal qualified health center perspective, there are various types of programs that are supported by the federal qualified health center. We happen to be a part of what's called a 330 grant, and a part of the 330 grant, there's different funding models. So there's a, Federal Qualified Health Center, which is term 330B. There's also 330H, which is specifically for homelessness. And then there's 330, I think it's H, which I believe is for, or I think it's 330I is for public housing, and then 330 H is for seasonal or migratory workers. So you have specific models that the 330 program, which is an Act 330 program, funds. And in each of those models, it's a little bit different, right? So when we talk about language barriers, cultural barriers, let's just even think about, which we are not, the model of having a health center that specifically supports seasonal or migratory workers. In that environment, you're definitely going to have potential language barriers, which means that you also have to have supportive interpretive services in order to support the clients that come and see you. And so with that said, if they did not have that service of medical interpretation available for the provider and for the patient, then of course, specific medical information would be lost,
Yeah.
and therefore it would limit the provider's ability and impact the provider's ability as well and medical decision making. And because based on that medical decision making leads to decisions that he or she will have to make related to the care of that patient. And then on the patient side, based on what is found through various tests and evaluations and assessments, they will then have decisions to make based on that information. And if the barrier then is language or even cultural, because that's why I think it's very important too that we remember when we're delivering care, and even for non-clinical interactions, meaning when we talk about patients coming to the health center, they're interacting with persons at the front desk or
Yeah.
non-clinical, and then they're going through their journey through the visit. It's very important to make sure that we are being very sensitive to various persons in the community who may have cultural or language implications that we need to be aware of. So going back to the migratory seasonal worker example, in that community, there are definite, cultural, language, and social aspects that we as providers have to take into account. Same thing as a federally qualified health center related to us. We are one of the smaller FQHCs in our state of Georgia and also nationally. And so for us, we have less than 20% of our patients who are identified as limited English proficiency speaking patients. But with that said, we are required to provide language interpretive services. But not only to that community, when we talk about language, we need to also talk about disability as well, because for persons who are blind or deaf, we also have to provide those services.
Yeah.
So from that perspective, it's very important for health centers to document instances where their patients need support. And one of those supports is around language barriers. The other support is around disability barriers. And so that could be vision or deaf. And then the other piece of that is providing culturally competent care. And so it's very important for providers and staff to be trained in providing culturally competent care, because we know through, and as you're aware, through when we look at the data on chronic disease results, as you are aware, African Americans and the Hispanic or Latino or Latina populations, our statistics are some of the worst when we look at various disease states, and that can be diabetes, hypertension, maternal health, those specific indicators show that African Americans and Hispanic or Latina persons have higher rates of incidences of those disorders. So, but when you look at the outcomes, and when you see that those same individuals have individuals who are taking care of them that understand cultural competencies and that understand how to partner with them on their journey, on their healthcare journey, their outcomes get better. And so that, and we know that that's the case, right? Because there's other studies that show that those persons who are taken care of by persons that look like them as ethnically and culturally behave the way that they do, there's a deeper connection between that provider and that patient, which leads to potential better outcomes because of that connection. So definitely language barrier, cultural barrier is very important in the practice of medicine.
Yeah, I totally agree on that. One of the, I would say, bad practices is to bring, family members and kind of bypass, provider could get by with,
Mhm.
what's in the room. I wonder what's your
Mhm.
position on that, if you have your stories around that, or yeah,
Mhm.
around.
Well, I think, historically, organizations have used in certain instances, and I've been witness of it too, that sometimes the patients will want to use a family member or a friend who speaks in their same language to serve as their interpreter. There are instances where that happens. There's also instances where we have staff who are bilingual or some even trilingual who will also assist, and all those things are helpful. I think where we have to be careful is, we need to make sure that those individuals who are interpreting, that we have a mechanism in place where we train them on really medical interpretation. And I say that because I've had instances where, what was supposed to be communicated to a patient was not.
Mm,
And then that led to different medical decision making errors, in my opinion, that could have been avoided if the patient understood completely why they were coming to receive care. And so, because in this example, the patient did not, they were unaware of what type of medical services they were coming to have to be provided to them. Excuse me. And you never want a patient to present to an institution and not know completely and be fully aware and engaged about what services are about to be delivered for them. And I know of a case where that was not the case for this one patient. And unfortunately, the family member who was accompanying them didn't communicate clearly what they were coming to that institution for. So, with that said, it's always been important to have, in my opinion, a certified medical interpreter, and that could still be a staff member of that clinic. I also believe, too, that for documentation purposes, it's also helpful to even document that exchange with the patient, because sometimes when there is a third party and they're trying to interpret for them, it's also good to have something documented that show, not something, but it is best practice to document the conversation. So if we ever need to go back to that
yeah.
exchange, the information is there. And it's also important too, I think, to have a third party there, because sometimes information can get lost in translation, and it still can between two people. I think the benefit of having a medical interpreter, particularly specifically, is that we can actually, keep the dictation we need to if there's any discrepancy related to what was communicated between the doctor or provider and the patient. And I think that's important because it definitely allows us to ensure that whomever is giving the interpretation has been trained to do so, understands the medical terminology, understands the nuances in medical interpretation in order to provide the best experience for both the provider as well as for the patient in particular that they're trying to communicate um, on behalf of, to ensure that both parties understand what medical needs are warranted for that patient. And then it also enables the medical provider in their best judgment to provide the best medical decision making based on the information that's been communicated. So I think, there's benefits in having a third party medical interpreter, in my opinion, for those reasons. As I think as we, from a patient population perspective, as you know, we are becoming more and more culturally diverse. And so I
Yeah.
think it's even going to become more and more important that we have a basis for and a grounding for training individuals in the medical interpretation space.
Yeah, totally agree. A medical translator, especially on site, I would say this is the golden standard.
Mhm.
I would say that the second will be video interpreter over phone, because video you get
Mhm.
to see face. But we're gonna talk about it. And maybe a question like from your experience, what would be the best way to train and prepare your staff to work effectively across those language and cultural barriers around professional development and things
Mhm.
that other clinics should look into.
Yes, I definitely think clinics should look into how to provide culturally competent care. I think clinics should also explore the benefit of maybe having staff certified as medical interpreters, not only from a non-clinical and clinical perspective, but even we don't even think about this sometimes is even from a billing perspective, to have a person who is bilingual or trilingual who knows how to communicate to a patient about their payment that is needed or about their medical bills. I think is very important, but I also think it's important too when we talk about those additional services that we provide to patients like care coordination or connecting them to specialists. So really trying to think about how do we provide culturally competent care throughout not only the in-person or virtual patient visit, but also patient engagement after the visit, right? And that's both in writing as well as in person or virtually. So for me, one of the things that programs can do is they can bring in persons to talk about cultural competent care. What does that look
Mhm.
like? What does that look like at different roles? Because it is going to be different when we talk about how does it look for a front desk person? How does it look for a phlebotomist? How does it look for a nurse? And how does it look for a provider? It is just going to be different. Also, not only having that type of training, but also status neutral training, right? To really think about making sure that all persons understand throughout the patient interaction continuum how to provide what's called status neutral care to everyone. The other piece that I would also, advocate for, not only having training for staff, not only front desk staff and clinical staff, but also providers on medical interpretation. Because I think it's a different experience when you know that your provider speaks two or more languages and you can specifically, coordinate schedules to allow, providers who are bilingual, trilingual to be able to provide care to that population. And so now you're building somewhat of a pipeline. Well, not somewhat, you are building a pipeline for those patients. So I think those are the various ways that you can educate your staff as well as to provide professional development for them to attain some sort of certification in medical interpretation, because I think is very important. And then the other piece I would say that would be great is that you begin to poll your patients who are um, considered limited English proficiency speaking patients to really gauge and understand what their needs are and ask them questions around what can we do to improve your experience with us, and whether that be by services or whether that be by how we engage with you or how we communicate with you. That's important too, because just like we survey patients in our practice, we survey patients after every visit about their experience. I think it is helpful to also survey, a cohort of patients like LEPs, just to get additional information about how we can provide that patient population a better experience, given their additional need of making sure that we provide adequate limited English proficiency speaking services, i.e. translation services, so that they can understand the type of healthcare needs that they may have.
Maybe going back a bit on the on the medical translation part. It's kind of an old problem. I think we have medical translation the last, I don't know, 40 years or so. I wonder, like, how was the technology changed throughout the years from your perspective to cover those gaps, and what innovations have you found most promising throughout the years?
Well, in my over 15 years experience, I've seen medical interpretation go from having in-person medical interpretation where, we had to request a medical interpreter, and then we had to cover either 2 or 4 hours of that medical interpreter's time, and they would come to the hospital and regardless if it was 2 hours or 4 hours of time, we would still be charged for that time, and then of course the hourly rate. So we would be charged with the hourly rate plus the transportation piece of at least 2 or 4 hours, depending on the contract. And then I've seen that evolve to telephonic interpretation and then video interpretation, which I think is great because you can do either verbal or American Sign Language for those patients who need it. And to me, that's a game changer. The other piece I've seen too is that from a telephonic perspective, we've been able to provide also three-way medical interpretation communication. So when a patient calls us in particular, we're able to, from a patient appointment scheduling perspective, if we notice that the patient is limited English proficient, then we can actually connect them to our telephonic interpreter, and then it's a three-way call now. And then the interpreter, the the staff member, and the patient are all on a three-way call trying to complete this one function of patient registration, patient appointment scheduling, et cetera. So from that perspective, what we have is now we have the ability for the patient to be seen and heard, right? And so for me, I've seen that evolve from that, in-person individual coming to the organization and sitting with the patient and then speaking to the patient and the provider um, as they, walk through the various paperwork that's involved, as well as having the ability to communicate between the two during the visit about the medical care that's needed or in medical decision making. And so that's evolved from that point to now having it be telephonic and now having the video interpretation. I think those are wonderful game changers, particularly the video, because now with the expansion of telehealth, like, and even for us in our organization, particularly for behavioral health for us, 50% of that patient visit population is telehealth. And so that's big. And I think you'll notice in the health industry related to telehealth, engagement, behavioral health, or mental health is one of the service lines that has the highest adoption of telehealth encounters, if you will. And from that perspective, we can now, if needed, have even on a telehealth basis, we can also request interpreters. So I think, the video piece has allowed us to grow along with telehealth in order to make sure that, LEP patients are getting the same type of care from an access perspective as our non-LEP patients. And that's important because that means that we are providing consistent care to both groups, or regardless of their ability to speak the national language. And I think that's important because at the end of the day, what we want for our patients is we want them to have the best version of what they feel like is optimal health for
Yeah,
themselves. And so by doing these things, we're hoping that it aids them in that journey.
yeah, totally agree. I think also the COVID period give a
Hmm.
lot of boost to the video, kind of the video component. Maybe it was kind of
Yes.
overlooked, but now it's kind of obvious. So
think, I think when COVID hit, we were converting to telehealth, and I can tell you the organization I came to prior to this organization, we had two clinics, and we decided to convert one to in person, another we decided to do telehealth.
Mm.
And I think too, some of the billing and payment practices from insurers, particularly CMS, also opened the door to providing more telehealth services, given that telehealth service payment and billing rules were changed for that period. And some have maintained, some of them have not. So I think because of COVID, and because of the implications COVID provided from the ability of patients being able to see by their provider, opened the door, I think, to expanding the use of telehealth. Because as you know, before COVID, telehealth adoption was not as great as it was during the COVID period. So with that said, I think that because of the changes in health plan, health payer billing practices and
Yeah.
payment practices, it actually enabled telehealth to spawn into multiple, environments, and that's, medical services, behavioral health services, and so, and even dental in certain parts of the country. So, with that said, it's very important to have, as you're expanding in telehealth, the ability to connect with your limited English proficiency speaking patients. And one of those ways is making sure that you provide that same um, translation service benefit when they're doing telehealth, because even during that time, it was very important as well. Don't have any data around the well, I haven't seen any data yet around um, the um, the quantity and also the effectiveness of having translation service, or what the effectiveness of providing language interpretive services during the COVID period. I haven't seen any data about that, and then if it was consistently used, if patients who are considered LEP, when they did receive care, did they do it by telehealth in person? And if it was telehealth, what was the experience? I haven't really seen any data on that. I wouldn't be surprised if there was data on it, because I would be
Yeah.
curious to see that, because during that period we had to pivot to that. And so, so I think that you're right, that because of COVID, it really spawned the evolution of telehealth, and I think it's great. Now that we're not necessarily past COVID, but what you've seen sustained from the COVID experience related to service offerings, the highest service that utilizes, telehealth is still behavioral health, mental health services um, that you still see. So that has been able to retain itself. It still has been impacted, but still, when you do comparatively, that's one of the services that has been able to maintain the telehealth engagement of patients.
Yeah. Yeah. Agree on that. Maybe last question, again,
Mhm.
from your experience, what advice would you give to healthcare leaders who are just beginning to address language barriers in their organizations?
A couple of things that I would, offer to those organizations is one, first evaluate your patient population and determine if, one, what needs that group require from you. As you know, from a regulatory perspective, if you receive, funding from the federal government and any um, pathways such as, research, um, remuneration, you are supposed to provide language interpreter services to patients at no cost.
Yeah.
So most organizations and most private practices who opt in to receiving Medicare services, even Medicaid services, or who have specific funding from the federal government, um, they are required to do so. So most, as I said, organizations and institutions that receive that type of funding are already required to do so. So that's one. And if they're not, um, then, and that's part two of this, is then it's helpful to assess, and this is even if you're not receiving funding, is for all organizations, is to see in your patient population, what is your limited English proficiency speaking patient population? Do you know what that is? And if you do, what data do you have that reflects that patient population? Do you have patient visit data? Do you have patient satisfaction data? Because if you do, then from a recommendation perspective, I would utilize that data to talk about how do we provide more clinically competent and supportive care to this population. What is the percentage of patients that are LEP? What are the various languages are we seeing being spoken by our patients? And then what types of communication should we be providing to them, both written and verbally, to assist them in their health literacy, right? Thirdly, what I would ask the organization to do is to look at your human resource capital and evaluate who on your team, both provider and staff, are bilingual, trilingual, and then think about giving them professional development if they so choose to look at the opportunity to maybe become a medical interpreter. So when you have patients come in, you have designated persons who are subject matter experts on medical interpretation, and they can be advocates for your LIP patients. And this could range from persons who are referral coordinators to, patient appointment schedulers to providers themselves. And because what you end up doing then is you're now creating a community of individuals that can assist this specific population. And lastly, what I would say as a recommendation is that you evaluate these things on a routine basis. And that could be every year, at least every year, in my opinion, because things change. And you also need to strategically think about when you are opening other clinics or other sites or other services, who is the target population of those services of that site, and also reviewing if you're going to have a need for increased LEP services for that target population, target service, and if so, make sure that you incorporate the level of services that are needed for that population to make sure you're providing consistent, culturally competent, and quality care across your organization. So those would be the four things that I would say. And the last thing I would say is have a champion for LAP patients, but not only that, have a champion for promoting quality care from a culturally competent perspective. And sometimes, having that person could inform how we communicate to certain target populations, because we want to make sure that we're communicating in a very supportive, thought-provoking, as well as informative way. And maybe having a designated person to serve in that capacity would be helpful when we talk about how we communicate with our patients, how we engage with our patients, what does that look like, even based on the service. Because, and I will be specific and say, two of the service lines, like family medicine and PEDS, we deal with the family. So how are we communicating with the parents of a potential patient who could be, first generation Americans, and they have a grasp of English, but how do we engage that parent or guardian or parents or guardians on understanding the care that's being provided to their relative? So with that said, I think having a point person that understands how to provide these types of arrangements for a patient, I think is very important. So really having an advocate for this would be helpful. And that same person could also be the same person who looks at um, these activities across the entire system, which I think is important because you want to make sure that you're providing consistent, care and activities for patients who, no matter where they seek care in your ecosystem, that their experiences are identical.
Yeah, those are great tips. Right. Louis Simmons, it was a pleasure to have you in Care Culture Talks, and thank you so much for sharing your experience and your tips.
Thank you so much, y'all. It was great being here, and I enjoyed having this conversation, and I look forward to hearing what other people thought about the experience. But I thank you so much for having this podcast and really talking about this ever increasing important topic.
Thank you.